in the outpatient. Today we're going to discuss infectious disease pearls in the outpatient setting. I'm Dr. V.
Hi, Dr. Horn.
Great. So first, we just always want to share where we find our guidelines. Most of infectious disease guidelines can be easily found on Infectious Disease Society of America, which is IDSA. And they have antibiotics, how to use them, infectious guidelines by organ system like endocarditis, CNS infections by organism. So it's a really cool way to get the guidelines you all need. So make sure it's free and easy to use.
Yes, and we like everyone to know where we get our recommendations. And so if you ever have a question about a recommendation that we make, please email us and we'll send us, sometimes we'll send the link, or we can send the guidelines, and sometimes we can highlight it just to show you exactly where we got it, because they're so large sometimes. But yes, we like everyone to know just where we get our information. And if you have a different guideline or a new article or something like that, we always love to see that stuff and incorporate that into our practice.
And some of the information presented today, there's some newer articles too, and the references on the bottom as well. So first thing, we always like to start off with especially in the outpatient setting too, how do you read an antibiogram? And also, how do you look at what is susceptible and what is resistant and what is intermediate? And one of the biggest things that we always hear is, and I know we have talked about this before too, if one antibiotic has a higher number than the other antibiotic when it comes to susceptibility, a lot of people think that the higher number is bad. And it always comes down to, for me, you don't compare antibiotics to antibiotics, but each antibiotics has its own cutoff point.
Yes, you can't compare one to the other. And that's very important, because sometimes people will call and they'll say, I'd like to start amikacin because the number is lowest right here. And that wouldn't be the recommendation. The recommendation would be to look, see what antibiotic, what's susceptible and what you want to use and everything. And then see if there are any contraindications, any reasons you wouldn't use that antibiotic. But that's exactly right. I wouldn't compare one MIC to another.
Yeah. And then, so that's what we just talked about. So we wanted to kind of give an example, right? So in this case, we see a lot of urinary tract infections in our clinics, in ERs, in urgent care. So a patient might have a urinary tract infection, and of course, most of the time it's going to be E. coli, one of the gram negatives. And here we have a susceptibility pattern, right? And if you look at it, you're like, okay, amoxicillin number is 8. And then there's a lot of resistance. And then penicillin number is 4, piptazole, zosyn. So do you think amoxicillin is worse than zosyn? No, it just, again, it cut off is for each antibiotic. And the same patient has nitrofurantoin, which is 16, larger number, but again, it's for that antibiotic. So it's important to pay attention to, is it susceptible? Do they say S versus I, intermediate or resistant? And in this case, a patient who's outpatient, who just has E. coli, UTI, pretty stable, you could use nitrofurantoin, which is a really good option.
Yeah, exactly. That you wouldn't. I don't necessarily think of one antibiotic being stronger than another. Sometimes people say, "Oh, this is the strongest," or "This is the toughest," or something. It's essentially what will work for this infection. And so, yeah, ideally with stewardship, you would use the most narrow spectrum, one that would work for that patient, to reduce the likelihood of getting resistant organisms and hitting other bacteria that you don't need to hit.
And using the least amount of harmful antibiotic whenever possible. Yeah. So that's one of the things we want to talk about in outpatient area.
Yeah, and that's a common question that we get frequently. So, so when looking at the susceptibility report, think of what you want to use, but don't compare one MIC with another.
Yep. And then moving on to the next topic, we kind of want to incorporate what's happening in the United States currently. And I'm sure you all seen that we're starting to see polio, unfortunately. I mean, I have never seen a case of polio.
And neither have I, and I don't want to see that
Yeah.
case. Yeah.
So it's pretty sad. And one of the big areas in the outpatient setting that is we can do as healthcare system providers is that we can't vaccinate people, right? And what's happening, if you look at the information, so they had the first case of polio in Rockland County in New York City, New York, and the vaccine rates for kids is 60%. And this is something that we give kids at 2 months, 4 months, we'll get into the schedule. So what I think it's really great for in our community is that we need to really make sure our patients are up to date on their vaccines. Kids, adult, elderly, big opportunity.
Yeah, I think this is one of the foundations would be making sure people are vaccinated and preventing infection.
Yeah, and I'm reading some information that because of COVID-19 too, a lot of the vaccines rate in kids have fallen because less access to, a lot of lockdowns and things like that, vaccine hesitancy. So it's really important to get everyone up to date on their vaccine. CDC has really nice vaccine schedules. And as you could see for kids, for example, and they have it for adults, they have it for catch-up schedule. So you could find anything on the CDC website. And here's a nice way you should be getting polio vaccine at 2 months, 4 months, 6 to 15 months, your third dose, and your fourth dose when you're 4 to 6 years of age. So only having 60% of the kids vaccinated for polio is very unfortunate. So making sure we look at our patient population in our healthcare systems and making sure they're up to date on the vaccine is going to be really important, and advocating for that. And because we're talking about vaccinations, pneumococcal vaccine, right? There's a new version now, Prevnar 20. And if you look at the graph here, this is from Pfizer's website. Prevnar 20 is able to, we had Prevnar 13, Prevnar 15, Prevnar 20. And what we're finding in most of the cases is that Prevnar 20 is able to hit most of the stereotypes of infection that is caused by pneumococcal infection. And, as the winter months are coming, influenza is coming. One of the big things I always worry is like influenza plus pneumococcal strep pneumo or influenza plus MRSA infection, right? So just making sure people are up to date on the vaccines are going to be really important.
Yeah, and this, in the past, especially, it's been very complicated of which one do you give, Pneumovax versus Prevnar, and if they've already had one, what do you give next? And I think people were getting kind of frustrated at how complex they were making it, and really, there's making it simple. There's a great advantage to making things simple so people can remember and give the patients the right vaccine. And not have to look it up and spend a lot of time on it with a busy clinic.
Yeah, and again, if you look on the right-hand side, it says CDC still recommends, if you use Prevnar 15, then you should give Prevnar 23 later, at least. But if you use Prevnar 20, you don't need to give a second dose of any of the pneumococcal vaccine. So this is nice, simple, nice to give it to patients over the age of 65. So making sure that we know this newer recommendation and we are following is going to be important. Next would be some statistics on lots of antibiotic we prescribe.
Yeah, so the benefits of giving antibiotics correctly and everything, and just the volume of antibiotics that are given. I think everyone attending this presentation understands the importance of giving the right antibiotics.
Yeah, and the most majority of antibiotics we use are unnecessary, but it's interesting to see the data. Amoxicillin and azithromycin are the most common prescribed antibiotic. And I think azithromycin, for me, I always see a lot of patients get prescribed azithromycin for pneumonia, ear infection, sinus infection. So know that azithromycin has a lot of resistance. It doesn't really work well for streptococcal pneumonia that well, higher amount of resistance. So just being aware of that is going to be important. So nice graph. This is updated. I think last time we were presenting data from 2016, and now they have 2020 data. So we could see how we are prescribing antibiotics in different states. So if you're a really darker color, it's not a good sign.
Yeah.
So lighter colors are better. So, for example, in Nebraska, we're prescribing a lot of antibiotics, 700 to 974 per thousand population prescriptions. So that's a lot.
That's a lot, yeah.
Yes. So we have a lot of opportunities decrease in prescription.
And then percent of visits for respiratory illnesses with an unnecessary antibiotic prescription. So when they look at unnecessary antibiotic prescriptions, there are some conditions that get a lot more antibiotics unnecessarily than others. And one of those is respiratory illnesses. So you have upper respiratory illnesses like sinus infections or colds is a big one. And so, when you see people, it's sometimes kind of difficult, even if you think it's a viral infection, sometimes clinicians feel like they need to give an antibiotic. They feel like the patient wants an antibiotic, or they feel like the patient may get angry if they don't get an antibiotic. There are some studies that look and they interview patients and they say, what is the reason that you're here? And it turned out number one was they want to find out what's wrong was number one, when the clinician's perception was everyone is the reason they're there is for an antibiotic. And so sometimes if you explain to the patient, that an antibiotic is unnecessary, they feel relieved, or they just, wanted to hear and make sure. I know it takes a lot of effort to try and explain to the patient that they don't need an antibiotic at this time. But that's what we're trying to do.
Yes.
Right? Yeah.
And some newer data too was really nice to break it down. Who is getting the most antibiotics and who's prescribing? So people over the age of 20, we are prescribing more antibiotics. Females are getting more antibiotics, males. In the South, there's more antibiotic being prescribed compared to other regions. And as far as providers, primary care physicians, nurse practitioners, and physician associates are prescribing antimicrobials the most. So if you want to make a microbial use, I think focusing on some of our primary care physicians and outpatient, it will be really helpful. They're doing the best that they can, but anything that we can help to help would be and reduce the antimicrobial uses. And of course, there's a kind of good study illustrating antimicrobial prescription in the emergency department, because we prescribe a lot of antimicrobials, because a lot of patients come to ER as well. And again, it just illustrates, in the study over 1,000 patients, about 62% antibiotic prescription were assessed inappropriate, but and the rest of them, over 40%, were not appropriate. So, just like we know over and over, data shows that we're prescribing over 40 to 50% unnecessary antimicrobials. Here's a study that shows in a single center as well. And what are we prescribing antibiotics the most in the outpatient setting, in ERs, abdominal, CNS, dental, ear, nose? There's a lot of things we want to go through, but we will do a follow-up presentation to cover some more topics. So the first topic we want to kind of touch base is GI infection, because I know somebody emailed and asked about diverticulitis. So we want to talk about, we see a lot of diverticulitis in our primary care setting for patients coming in with, and we're prescribing a lot of antimicrobials. And, when we see diverticulitis in the hospital, it's when it's bad, right?
Yeah.
Yeah.
Right. Yeah. When they get admitted to the hospital, then, it's not going so well.
Yeah. But, a lot of times they don't get admitted to the hospital. And, annually in the United States, 1.9 million outpatient visits are happening, close to $5.5 billion in diverticulitis cost. And incidence of diverticulitis actually, unfortunately, are increasing. Younger and younger individuals are getting diverticulitis compared to now versus 1980. So one of the big questions we get always asked is like, how long do you treat and how do you treat diverticulitis? So the reference guidelines is from the new GI journal guidelines, where they talk about like, get a CT scan, confirm they have diverticulitis, use antibiotics appropriately, then of course rule out malignancy and risk factors. But when it comes to antibiotic, Dr. Horn, like what kind of therapy would you recommend in outpatient setting?
Oh, yes, that's a good question. And yeah, just as it says, when it comes to abdominal infections, I usually think of two things: the severity of the infection. Is it moderate or severe? I never say mild.
Yes.
Is it moderate or severe? And then the second part is it source controlled or not source controlled? And when you're choosing antibiotics, it's just going to be, as this says, it's going to be either a one drug therapy or a two drug therapy. And when you give a two drug therapy, it's because you're adding another antibiotic for anaerobes. So yeah, the recommendation would be, and if the one drug therapy includes anaerobes in it, then that's why you would choose a one drug. So you could use, like this as Augmentin. Augmentin is a good one drug therapy because it also has good anaerobes. It covers anaerobes well. And then a two drug would be something like a fluoroquinolone plus metronidazole.
Yeah, I kind of don't like fluoroquinolone, so
Yeah,
I
if you
know
can get away with not giving
yeah,
a fluoroquinolone and just giving Augmentin, that would be a better plan.
yeah. So we try to use more Augmentin
Mhm.
because it really covers your gram-negative bugs, anaerobes, gram-positives. And also, some nowadays I'm also doing like ceftonir flagyl, so it's a
Yeah,
cephalosporin, it has gram-negative and gram-positive, and then kind of avoiding the fluoroquinolones as much as I
yeah,
can.
and that's exactly what I do.
Yeah.
Yeah, and the reason is because if you look at our antibiogram,
Yes.
if you look at ceftriaxone and you look at third generation cephalosporin, and then you look at third generation cephalosporin pill, it's going to work similar to that ceftriaxone. So it's if you give a third generation cephalosporin like ceftonir plus metronidazole, that's more and more I do that because
Yes.
our Augmentin, our antibiogram, for some of the hospitals here, that isn't great.
Yeah. So I think those are your options. And for me, when I did residency, it's always like 14 days for diverticulitis.
Yeah.
But now, if it's moderate, I wouldn't say mild, if it's moderate and they're doing okay in the outpatient setting, they're saying usually a 4 to 7 day course of antibiotics is okay. So team is always less is better. So like 4 to 7 days is okay, unless it's really complicated, large abscess perforated, it's a different story. But if it's a small diverticulitis, you could do a shorter course and it's okay now. So just remembering that is going to be important.
And then, so this is C. diff infection in adults, and C. diff is continuing to evolve and change. And I think it's good to include this here also because when it comes to options for C. diff, we just want to make sure everyone's on the same page and everything.
Yeah, and with C. diff, it's a focused update that happened. And we talked about it last year, but just want to remind everyone in the outpatient setting, now the Infectious Disease Society America guideline says fidaxomicin is on the top compared to vancomycin. And that is because fidaxomicin has shown to reduce recurrence. So it's helping reduce recurrence of C. diff. So ideally, if there's no resource limitation and the patient, you could get the drug, what they're recommending is fidaxomicin for 10 days. If you cannot get fidaxomicin because it's so expensive, then you could do a vanco. Obviously, don't use flagyl. It's not appropriate. There's over 50% of C. diff strains are resistant to flagyl. Only place it has is when you have severe fulminant C. diff, you have one IV option. So fidaxomicin is your number one for C. diff. If you cannot afford it, if they cannot get it, resource limitation, then vanco is your secondary. And then if you have a C. diff that comes back again, first episode, second episode, they're really advising to give bezlotoxumab in outpatient setting. So that's why we thought we should talk about this now because it's an outpatient medicine, the bezlotoxumab. We have done it on a few of our
Mhm.
patients recently who have had bad C. diff in the outpatient setting.
And I want to highlight this part also, you can also give fidaxomicin twice daily for 10 days, or you can give it twice daily for 5 days by every other day, and you give it essentially the same number of pills. It's just you spread it out and give it over a longer time frame, and that's a very good way to give it, and that's I think the lowest recurrence rates of anything that's been studied.
So do it twice a day for 5 days, and then you would every other day, once every other day.
Yep,
Perfect.
until it's gone, and that's how I like to think about it, because
Yes.
it's the same number of pills.
Yes,
It's just a different way of giving it.
that's great. And then bezlotoxumab, we're going to talk a little bit more detail. Again, they're recommending so let's say somebody has C. diff for the third time, right? They're still recommending, if they didn't get bezlotoxumab before, please give it this time too. So just that should be becoming part of our practice now. So in the outpatient.
And that's to lower reoccurrence rate?
Yes,
Yeah.
lower reoccurrence, because it's a monoclonal antibody that binds to the C. diff toxin area, and it helps, and it lasts for like good 6 months. So they really recommend giving it in the outpatient setting. So again, it's usually insurance don't cover it in the inpatient setting. That's why it's an outpatient drug, and make sure we think about it. And why and who should get bezlotoxumab? It's about $4,000 to $5,000. I think depends on what kind of formulary and contracts you all have. But the patients who they recommend are patients with recurrent C. diff within the last 6 months. So it doesn't matter whatever age, if they're having recurrent C. diff. If you're older patient with C. diff, so over the age of 65, immunosuppressed host, Crohn's you have Crohn's disease, you're on steroids, you are a cancer patient with treatment with chemotherapy, severe C. diff presentation. So you got admitted to the hospital, you did really bad, had a C. diff case. And then if you have lots of comorbidities, these patients really, we should be giving them outpatient bezlotoxumab if you're able to obtain it. So something to think about. And for us in how I have done it in our infusion clinics, been able to get the drug, make an appointment, and the patients when I've been able to get that. And next, we're going to talk about skin and soft tissue. So we're going pretty fast, but please ask us questions. And some of these topics, we could also do it individually as well.
And this again is from the IDSA guidelines. And so we like talking about guidelines because that kind of gets everybody a same foundation and a good starting place, since we're all on the same page. But these guidelines are actually, I think they're very good. I think they're very helpful. It's from 2014. And this is, I think, the most helpful thing, that if you look at this, then you understand kind of the guidelines and what they're saying. And this is management of skin and soft tissue infections. And the first kind of split point here, they're going to be pus or no pus. So there's purulent, there's pus, and then non-purulent, no pus. And if you're thinking pus, then you're thinking staph, like Staph aureus. And if you're thinking no pus, you're thinking strep. And so it kind of divides it. And this isn't perfect, but this is a really good way to think about it. I think this is how I like to think about it. And there are exceptions to the rule. I have seen some staph infections not have pus, but I'm not sure if that's how it was in that patient, or because it just wasn't evolved enough. It just hadn't kind of blossomed enough. But we'll start over here on the pus side. So if a patient has a wound with abscesses, so it says abscess, carbuncle, furuncle, if they have something like that where there's pus, in general, when you're thinking of a soft tissue infection with staph, there's pus, and it's kind of slow moving. And then when you're thinking of strep, you're thinking of no pus and fast moving. So it developed very quickly, and it can spread very quickly. And if you're trying to decide if it's a cellulitis, you're seeing it's red, it's warm, and it's painful to light touch in general. So if you're touching the skin, they have pain there with light touch. Now, some patients, they don't have any feeling in their feet or something. So that's probably the first question that you should ask is, do you have feeling in your feet, to see if they can feel that normally. But on the staph side, so you have mild, which would be generally an abscess that's smaller than about 2 or 3 centimeters. Usually how they define a mild. So you can just IND it, you can just cut it open and allow it to drain out, and they don't need antibiotics. Most of the time people will get antibiotics.
There are some newer studies that show that giving like even if you drain it, giving like a few day course of antibiotics help with recurrence prevention, especially with staph. But you're right, most of the time they heal okay. They could get maybe a 3-day course if needed, but you're right, most of the time.
Oh, sure. Yeah. And a short course, I'm always okay with very short courses.
Yes.
Yeah. And moderate, there's incision drainage and culture and susceptibility. And so this you can give, this is essentially no antibiotics and then pills and then IV antibiotics. And here with the pills, they have doxycycline or Bactrim. And then once you have the susceptibility report, here it says Bactrim, you can really give Bactrim or doxycycline if you have it. And then if it's MSSA, dicloxacillin or cephalexin, which is Keflex, we don't give very much dicloxacillin anymore because it's more frequent than cephalexin. But either one would be okay. We give more Keflex than dicloxacillin. And then for severe, it's going to be IV antibiotics with MRSA coverage, and then also here MRSA if it is defined. So if you have a susceptibility report or you see it's MRSA, you can continue one of these, or if it's MSSA, cefazolin would really be the best drug. And then here for non-purulent, if you have strep, you can give something PO if it's mild. Moderate, you can give something IV, and then if you're suspecting necrotizing fasciitis, then you would call surgery and get their opinion as well, and kind of go from there. But in general, if you're concerned about necrotizing fasciitis, you give vancomycin plus Zosyn, plus usually clindamycin to prevent toxins and toxin binding and things. But now one thing I wanted to just comment on is here you have empiric. So if you have pus, if you have abscesses, then the most likely thing is it's going to be MRSA. But it's kind of different. So if you have pus and abscesses, you're thinking MRSA, but if there's no pus, the most likely thing is going to be strep, and it's going to be a strep infection. So sometimes people will say the most likely cause of cellulitis is MRSA, but the most likely cause of cellulitis is actually strep, and then if there's pus, then it's MRSA. So that's kind of a quick run through of how we think of skin and soft tissue infections. Oh, and this is really good. So this is over here. You have what looks like a strep infection because it's red. It looks like it would be painful.
Yes.
And there's no pus, and so I'm thinking a strep infection. So you wouldn't necessarily need MRSA coverage here. You can give something like Keflex, or if they're in the hospital, you can give something like cefazolin, and then when they leave, you can give Keflex. So it's another first-generation cephalosporin. And over here, this has pus here, and so if you see something with pus, then you're thinking, you want to make sure that you cover MRSA. And so those are the type of patients that might get something like Bactrim plus Keflex if they're in the outpatient setting. And the Bactrim is to cover MRSA, and then the Keflex is to cover strep infections.
Yep.
Oh, and one more thing. Oh, I think we actually cover this too, but one more thing would be here you see if you're covering staph, Bactrim and doxycycline, but you don't see Bactrim and doxycycline on the strep side because they don't cover very well. And you can see that on antibiograms as well, that the Bactrim and doxycycline covers staph really well and MRSA, but it doesn't cover the strep very well. And over here, Clinda covers strep really well, but it doesn't cover staph very well.
Yeah, and I want to kind of I like that point that you made about like Bactrim and doxy, because clindamycin actually is really good for strep, but over 50% of Clinda is resistant to MRSA. So depending on the antibiogram, like I don't like clindamycin to start with because a lot of C. diff and all the other things comes along with it. But over 50% is resistant to MRSA, so you have to be very careful. If you don't have culture and susceptibility, don't use clindamycin as preemptively, right?
Yeah, no, I feel the same way. I don't like clindamycin in general, but it's okay to give usually someone that has a allergy or something like that. But I but it's not to be given to think that you're covering MRSA. Yeah,
Yes.
that's exactly right. Yeah, it's okay to give just as long as you know that you're not covering
MRSA.
Yeah.
And for MRSA, I think, like you just said, Bactrim, Doxy, and linezolid also is another option. Powerful, so I don't use it all the time, but if you need it, it's there for you. And then other skin and soft tissue stuff that we see is bites a lot. Dog bites, cats bite, human bites, sometimes even like other animals. I have had camel bites and cow bites.
Cow bite, yeah.
Yes. And for the most part, the bacteria we're looking at is Pasteurella, Capnocytophica, Echinella. So ideally, the drug of choice is Augmentin. And if you have penicillin allergy, Doxyobactrim or Levo plus Flagelloclinda. So always a 2-drug regimen is important. And these are the times when even if you get a bite, you don't have an infection, you should treat them. So prophylactically treating them for like 5 days or so, because those bites can develop into bad infection. And especially cat bites, they go deep. Those teeth are really deep, and you can get osteomyelitis, tendonitis. So if somebody, other thing I always say is, you try Augmentin in the outpatient setting for somebody who got bit, and then they're still not getting better, and they come to your clinic again to say it's not getting better. It's not because the antibiotics is not working, because a lot of times when you have bite, you have deep infection, and you have to like image to see, do you have an abscess, do you have osteomyelitis? So always remember that as well.
Yeah, and I think the only other thing I have, I think that's exactly right. The only other thing would be clindamycin.
Yes.
I wouldn't recommend clindamycin here.
Yes. Don't use it by itself. If you use it, it has to be in combination.
Yeah, I think, it's always.
So Doxy, Bactrim, Levo plus Flagelloclinda.
Yeah, we've seen a lot of bad dog
things.
Bites and cat bites and
sometimes we see in the emergency department and stuff, they give for bites like Caflex, and it's a big no because Caflex does not cover Pasteurella, Capnocytophica, Echinella. So those type of patients get really bad.
That's a really good point. No, I've seen people recommend it before, and I'm not really sure why they're recommending that, because it doesn't cover the most likely things that they're going to get.
And that's why we put it in skin and soft tissue here, because this is a different thing on itself. So Augmentin, because it's amoxicillin, clavulanic acid works really well together, or you have to have combination treatment. I've seen really bad cases, septic shock in the ICU, because they were given the wrong treatment in the outpatient setting. So this is really important. And then now we have upper and lower respiratory infections. So 2019, we had guidelines change for community-acquired pneumonia. And, it's always important in the outpatient setting to say, hey, are we going to treat them in the outpatient setting? Am I going to admit them, or are they going to go to the ICU? And I know, Dr. Horn, you like to talk about CURB 65, the points.
Oh, I do, just to, it's good to know about, and it's because people will say, well, what does it matter where they get sent? And if they get sent to the medicine floor when they should have gone to the ICU, the studies show that the outcomes aren't as good. And so if they get sent to the medicine floor and within 24 to 48 hours they transfer to the ICU, then they probably should have been sent to the ICU first. And so CURB 65 is what I like to look at, because it's easy to remember and to use, and you don't need labs for it. So pneumonia severity index score is a better tool, but I should say it's a better predictor, but it's a harder tool to use, because you need so many things and to look at. So the CURB 65 is the one I would recommend.
Yeah, and if you have like one point or less, then you could treat them in the outpatient setting.
Oh yeah, so and you don't need labs, you can just look at it and know it.
And then the reason you don't need labs, if they're doing okay, then like what is the most common bacteria, right? Strep pneumo. That's why I was focusing on getting everybody vaccinated. Haemophilus influenza, chlamydia, and other respiratory viruses that we're going to see. So what the newer guidelines recommend is you could do amoxicillin. If they don't have risk factor for MRSA or Pseudomonas, you could use amoxicillin, doxycycline, macrolide. Again, azithromycin, lots of resistance for strep pneumo. And if I look at my antibiogram, it's over 40% resistant, so I wouldn't use it. So it's really important. But with people with comorbidities, they recommend combination such as Augmentin or cephalosporin with the macrolide. And that's what we usually do. We use a beta-lactam therapy with the atypical therapy that'll cover your Haemophilus and chlamydia. So you try to do azithro with Augmentin, ceftonir with azithro with Augmentin, ceftonir with azithromycin. So like a combination therapy. You could always do again fluoroquinolones by itself. I don't like it because of all the C. diff and resistance. So something to think about.
And then as far as antibiotics, most adult patients need 5 days of antibiotic therapy for community-acquired pneumonia. So 5 days is where we're at right now. So it keeps slowly coming down as far as duration of antibiotics. And, I think after a while, it's probably going to go even lower than that. It's hard to make a recommendation for everyone in every situation. But 5 days is where we'd start right now.
5 days is plenty for community acquired, but data still shows we're doing up to 10 days. So just think about being 5 days being enough for a patient. And then of course the next thing is we see a lot of ear infections. Again, pretty much ear infection is similar bacteria that causes pneumonia to strep pneumo, Haemophilus, sometimes Moraxiella. And viruses too, and therapy-wise, Augmentin is great, ceftonir is great, but something to remember, this is from CDC, you don't have some ear infection, you could watchfully wait, especially in kids. A lot of time ear infections happens in kids, 2 to 3 days to see if it gets better. If they don't feel well, fevers and chills, then if it's a mild to moderate, they recommend 5 to 7 days of treatment. Shorter course again, but if it's severe, having lots of other complications, then maybe go up to 10 days. When I did residency, we were at 14 days for ear infection. So 5 to 7 days for ear infection is plenty of antimicrobials. And then next would be sinus infection.
So sinus infections, it's sometimes kind of hard to tell if a person has a sinus infection. But yeah, there's a picture of the fluid. So but yeah, I think, when it comes to sinus infections, before they were saying if you lean forward, I think you feel this fullness. There are some other, things that they talk about also when it comes to, do they have a sinus infection or do they need antibiotics or not? Generally, I think the time course is, how long has it been going on for? So I think, is it 10 to 14 days if they've been having symptoms that keep going on and it's not getting better? There it is. It does not improve within 7 to 10 days. So if a person comes in and they say, I've just had this for 2 days, the most likely thing is it's going to resolve on its own and go away. But if it continues to go on for 10 days without resolving, then that's when you would consider giving an antibiotic.
And one of the things I really like recommending my patients is like nasal rinses. And before they used to do neti pot and nobody likes that stuff, but now they have really cool, like just saline sprays that really cleans it out. So, patients are having sinus pressures, like asking them to just clean out the nasal passage with saline sprays, so much over the counter really helps a lot.
And if you do use a neti pot, it's important to use one with, is it boiled water or you just
sterile saline?
I'll get that sterile water from the store.
I mean, I'm hearing Naegleria.
Naegleria. Yeah, that's why I say that. I didn't want to scare people.
It's a parasite that's in like tap water and stuff sometimes and can cause the brain infection. So really, sterile fluid is the best. And I love the saline sprays. They're fantastic, easy to do, not complicated. So that really helps. But again, the big question is, how long do I treat sinus infection, right? Now it's just 5 to 7 days. For the most part, 5 days is plenty. So we don't need, again, when I train 14 days, we're at 5 days, which is fantastic. So I think take away today's 5 days for everything. And still we're treating patient for 10 days for sinus. So 5 days is plenty of antimicrobials for sinus infection. And, just want to close it off with, in 2022, We have lots of other stuff going on, polio, now
Yeah.
monkeypox. So I know we talked about polio earlier this month, monkeypox earlier this month, but we really want you all to pay attention and keep an eye out, because a lot of patients are not getting diagnosed on time with monkeypox. So if you see a rash, keep in your mind, this could be monkeypox in the outpatient setting. If they say they have lesions in the genital area, think this could be monkeypox. Patients are presenting with penile lesion, vaginal lesion, rectal lesion, so think genital lesion could be monkeypox. High risk patients are men who have sex with men, patients living with HIV, immunosuppressed patients, and then of course, pregnant women and children, they can have severe disease as well. Please keep an eye out for that. If you think you have a patient with monkeypox, call your health department. They could give you antiviral. If somebody gets exposed to monkeypox, we have vaccine that can be given as post-exposure. And if you have high-risk patients in your community, if you have patients in your population, in their health system, that are men who have sex with men, patients living with HIV, they have vaccines that we can give it to patients even before they get exposed. And health departments are allocating vaccine doses. So look at your patient population that you're serving and really making sure we're helping everyone.
And if you have any questions about this, remember that we're available. So
Yes.
with all the hospitals we work with, you can call us anytime to discuss antibiotics or any kind of monkeypox questions, any of these things that you want to discuss, or infection control and prevention. We're happy to answer all these questions, and we're always available.
And one of the things I'm noticing right now is that patients are coming into the healthcare setting, in the outpatient setting, multiple times with lesions and genital lesions. And they're getting thought of for other diagnoses, and monkeypox is not on one of the diagnoses. So we really have to think about it, and we have to help our patients.
Yeah, I think part of it is that they're expecting it to look a certain way, and it doesn't look like the classic pox that sometimes, or even if it does, they think, oh, he's not that sick or he's not that bad. But I think that's one of the big points that you made, was that to consider it, even if it doesn't look like a classic pox lesion. Because more and more, that they're seeing it kind of present in kind of a new way.
Yeah. And lastly, COVID-19 is still with us, going to be with us. And we are seeing a lot of disparities, and primary care providers and any providers are still not prescribing a lot of Paxlovid to patients. So really want to remind everyone, Paxlovid is approved for 12 years and older. And there's drug-drug interaction. Sometimes you could stop the other drugs for 5 days while they get Paxlovid. But this really helps with stopping the virus from multiplying. And it helps with symptom improvement, hospitalization, and mortality. So we really, and there's no shortage anymore of Paxlovid. So I think a lot of people are concerned, am I giving this unnecessarily? We are shortage, there's no shortage.
Yeah, I want to ask your opinion, because I feel like my threshold to give is so low. And even if it's outside of kind of the window, do you still, what are your thoughts about that?
So I still stick with that. Did your symptoms, actual symptoms, 5 days to give it? But for me, the threshold to give it to anybody is very low. Like if a patient wants it and they have COVID-19, I'm okay prescribing Paxlovid. I do review their medications and make sure there's no interaction. And I had a patient recently who was on amlodipine and Paxlovid. So amlodipine levels can go up. So I just told him to half the dose for 5 days. I knew he was going to keep an eye on his blood pressure. Another patient was going to just hold off his statin for 5 days. And then, so there's ways of doing things, but it really helps in patients with mortality, severe disease. So we should be using Paxlovid whenever possible.
Yeah, that's how I feel. Anytime even if it's outside the window, if they're very elderly, I think having a conversation with the patient and saying, it may be outside this window, but it may still help. And what are your thoughts? And discussing it with the patient. And but yeah, I feel like I think people are either really pro for it or not so much,
Yeah.
and I'm really pro, just like the vaccines. Yeah.
Well, I think we went over time. We're exactly at 1 p.m. Any questions for us? This is our last slide. Anything we should be aware of concerning the recent Nigeria for infection obtained in Nebraska waters? Yeah,
That's a good question.
Yeah.
Naegleria is it's one of those things that it's very rare but devastating. It's very
Yeah.
scary. Yeah.
It's actually, I was reading a lot about it. It's very common in waters to have
In lakes,
rivers, lakes. It's very common. So, but one of the things, what we have to be aware when we're swimming in these waters, not to get water in our nose, right? That's how it travels, not by swallowing, but going through your nose to your brain. So, telling people, if you don't have to take a swim in the lake, don't do it. But if you're going to do, swimming, like making sure you don't get water through your nose. So, keeping your head up. That's what some of the recommendation, the hand alert that just came out, and not swallow, not taking the water through the nose and it can travel is really important. I know it was very sad to hear that case on the child. So anything we can do to stay away from the water for a while. But if you're taking a swim, making sure water doesn't get into your nose.
Yeah, and even sometimes in some areas, in some cities, they'll find it in the tap water, and they don't get sick when they drink the water. They just get sick if it goes up their nose, like through a neti pot, or if they, for some reason, they got the water shot up their nose or something. So, even though it's in a lot of water and it's in lake water and sometimes it's in the tap water, the actual getting it is very very rare. So, but it is something that is pretty scary.
We will make sure to share the slides like we do after every presentation. So we'll share the slides with you all and the video recording. So we'll send that out within tomorrow. Any other questions, concerns? Well, thank you so much for attending. And please email us any topics you would like us to discuss. We have topics set until December, but if there's any urgent questions, we're happy to talk about. And otherwise, it would be nice to know what topics you all want for the next half of the year so we could do that for you. Well, have a great day.
Thank you very much, everybody.
Thank you.